Assalamu alaikum and welcome back to Medicower. Today's show is very much around your gut health. I've been talking to Dr. Raj. We've recently been talking about the bowel, where it is, how it works. We've also talked about signs and symptoms, which I know we're going to expand on a bit more. And we've talked about IBS. And before the break, we were talking about IBD and how that links to ulcerative colitis, which is a very hard thing for me to say, and Crohn's disease.
UC is easy.
UC is the easy way to say it. Okay.
Ulcerative colitis, UC.
So what else do we need to consider in relation to these things?
I think the main thing is why I wanted to mention these things is because these are very rare gut problems that we're talking about. IBS, as I said, was about 10 to 30% of the population, according to literature. IBD wise, Crohn's disease is probably about 145 people per 100,000 of a population.
Okay.
So if you have 100,000 people in a room, 145 of those would have Crohn's disease.
Okay.
Which, if you think about it, is not very much.
No.
So the other IBD condition, which was UC, ulcerative colitis, slightly more common. It's about 240 people per 100,000. Okay. But again, nowhere near the numbers of IBS, which is really, really common. The point I was trying to make was the fact that why we try to introduce these topics in, because some of the symptoms that you get from these conditions are very similar. And although IBS symptoms are a lot more tamer and they can be managed, you just got to be aware of the fact that you don't want to just keep ignoring symptoms, because there are a certain sector of that population where things could get mismatched and actually diseases can mimic other diseases. And it could be that it's not one of the really common like IBS type symptoms, but actually the early stages of something more serious like IBD, which is Crohn's and ulcerative colitis.
If a patient goes to see a doctor and has some of these very vague or broad symptoms, what kind of testing is going to help the doctor to fine-tune and get a sort of an answer for these?
So we do everything systematically. It has to be systematic. And anyone you go to will be trained to do it in a systematic order. So the first thing we do is
what do we mean by systematic?
So systematic means we have a system in place. We go from one thing to another and we keep on kind of going down this kind of protocol.
Also there's a style in which you do it.
There's a style which you have to do it. So the first thing we always have to do is take a history, which means we have to ask you all the questions. And that can be slightly embarrassing for some people, like asking them about their bowel habit and how often they go. So the most important thing I need to get across is you shouldn't be embarrassed. What you think you're embarrassed about, we've seen 100 times before. It's not really anything we get embarrassed about. You need to be, relaxed. You need to be truthful, and you need to tell us what's going on. And
I guess if somebody is really embarrassed, they could write it down and bring it on a slip of paper if they were really struggling with that.
Often we get partners come in with people, and they sometimes say, actually, well, he or she's a bit embarrassed, and we're concerned about this. What do you think? And then we can have an open conversation. Having someone there in terms of a family or family friend even. It does help in terms, not just to kind of get the point across and open up the problem more, but also as a support mechanism afterwards. Once you walk away, you don't have to think about all those things that I've said to you by yourself. You've got someone else you can bounce ideas off and you can work together.
And I have to say, the more I hear you talk about this subject, the more I realise that what people must be living with in relation to these conditions can't be easy. No. It has a real massive impact on their quality of life. So it is important that they get the help that they need. Completely.
After taking a history, next step is to do an examination. So the doctor you'd see would lie down on a couch and do kind of a head-to-toe examination on you, but especially focusing on kind of what we call an abdominal exam, which basically means having a look, feel and a listen into your abdomen with a stethoscope and feeling your abdomen with their hand. And
that identifies tender patches
as well, doesn't it? Tender patches, it gives us a lot of information. But we think an examination is important. It is, but normally the history is far, far more important. Because normally, if you listen hard enough and you ask the right questions, the doctor will normally work out what the problem is in the history. And we don't normally, an examination is just there to confirm some findings sometimes.
I always say doctors are like detectives.
Yeah, so it is a lot of detective work, but the history is really, really key. So don't be embarrassed if we ask you loads of questions about, you know, like we said, like what's in your toilet, how often is it coming, what the consistency is, it's just part of what we need to do in order
So
to
it's
try
really
and
good
work
then
out.
that people think about that before they even see the doctor. What
So
do they know? Keep an eye on what's happening.
keep an eye out, exactly. After the initial history and examination, the next step is basic investigations. So we always do kind of basic investigations, and then if those are shown up some kind of problems or some kind of areas that are a bit iffy, then we want to move on to some more significant investigations.
So what comes under basic?
So basic investigations would be things like a blood test.
Right.
So we do blood tests. Your blood is amazing. It's just the amount of things your blood can tell you. I know you had a separate show just on blood. I remember I watched it. The amount of stuff that is in your blood is phenomenal. And as a doctor, it helps me try to clarify and work out what exactly is going on. It can tell me about how your liver's working, how your kidneys are working, and also how your gut is working in this instance. How your body's reacting to things as well, which is important in things like Crohn's disease and IBD and ulcerative colitis, just because your body will be reacting to something. And your things like your police cells of your body, the white cells, you may have heard of those, they may be raised. Some of your, we call inflammatory markers, which are like they're like chemicals in your blood that get raised, they go up when your body's going through a process of inflammation, when it's reacting to something. Not necessarily an external thing, could be that it's reacting to something internally. Those chemicals go up, and we can measure those and look at trends and stuff. So it's really useful. So blood tests are a useful start point. And then from there, we can do things like x-rays. And then occasionally what we have to do is move on to some more significant investigations. And those things we were going to talk about a little bit more shortly.
Is this the endoscopy and colonoscopy?
Exactly, yeah. So
investigative camera I've got on my list.
No,
capsule cameras.
Capsule camera. So a capsule camera is it's a fairly new technology, but let's just focus on endoscopy firstly, just because it's far more common. So lots of your viewing audience may have heard of camera tests or endoscopy, and it's all a bit weird, isn't it? It's all like it's a bit scary, and people don't like talking about it because it's a bit weird, and it's a bit of a taboo topic.
Many people
sometimes
have to psych themselves up to cope with a test like that because they're frightened by the gag, because the endoscopy is the one going through the mouth, isn't it, and the colonoscopy is going the other end.
So endoscopy just means a camera that's going inside you.
Right.
It doesn't specify which side it's going.
Okay.
No. So the top one here, we call it an OGD.
Right.
Yep. The top one from the top end is an OGD. The bottom end is there's multiple different types, but it depends on how far. If you look on here, it depends on how far we're doing the camera.
Okay.
So there's ones that just go a short way, and that's called a sigmoidoscopy.
Yes, I've heard of that.
And they can be. There's lots of different types of sigmoidoscopy, and then there's ones that go a bit further around. They can go all around the large bowel and poke into the small bowel here as well, and that's called a colonoscopy, because this is the full colon, and it's oscopy just means camera to view it. So this is a full colonoscopy. A sigmoidoscopy just looks at this portion of the large bowel, which is called the sigmoid colon.
I think it'd be quite reassuring, and you can reassure our viewers, which I might not be correct on that.
Yeah.
I think with modern technology, you've got quite small cameras there, because I can imagine people sat there thinking, oh my God, this sounds like a really horrific.
These tubes are like probably my little finger, the diameter of your little finger.
Yeah, and some might argue that's still quite
some people think that's probably, that's fair enough. I mean, for the kids ones, we've got smaller ones, but you need it big enough so that you can actually see an image. Otherwise, there's no point in doing the test.
Yeah.
It's all risks and benefits. If you do a test and you don't get the results you want, then there's no point in doing the test.
Yeah.
So we needed a camera big enough with the technology we have at the moment. This is the best way to get the images. I
think there is another show to be done around these particular procedures because of how we help people to understand how to prepare for them as well. And
there is a psychological element. People do get stressed out about them, but it's very common. We do them every day.
Yes.
There are risks. There's no procedure without risk, because ultimately, if you do anything to someone, you are incurring risk in some way or another. We don't need to go into the risks of the procedure today.
But they're generally considered safe procedures.
They are safe,
aren't they,
otherwise
today?
we wouldn't be doing them.
Yeah.
And we do them on such a scale, you know, the mass on mass, and people can have we have special endoscopy departments.
Yeah.
Like in my hospital in St James's, there's a specific endoscopy department. They just do endoscopy all day long.
I had a friend who 4 times didn't turn up because she was so frightened because she didn't know what to expect, and I actually took her one day to talk to the team to say this is how she needs to prepare for this, and they were so helpful, and they got her through it, and it made a big difference for her to actually get the procedure done.
It's quick. I mean, the procedure, you know, if there's no problems and we just kind of doing it from start to finish, a top procedure from an OGD could be about 10, 15 minutes, 20 minutes. Bottom end about the same. You know, if there's something weird and wonderful we find, then we have to maybe do something about it or get some samples. So that's the biopsy.
But basically what you're showing on that diagram is very much that you've got opportunities without having to cut people open to do surgery to find out something that's important. So whilst it is something to be prepared for, we've now got technology that helps you have a good look inside without having to do surgery first.
We use local anaesthetics in the back of the mouth so that it doesn't feel that painful, or you get the gag reflexes calm down a bit. And then the camera goes down, we have a good look around, and then the key thing is that we can actually take samples. So and what that means is we don't take like massive chunks, it's tiny little microscopic little pieces. We can just take a little snip, a little pinch, you don't feel a thing, it doesn't affect you in any way, shape or form. And those samples can go to the lab, and they can look under a microscope and tell you exactly what's going on a microscopic level. So
this all helps you with your diagnosis of these particular conditions. I think it does it for lots of things, doesn't it? But we're talking about, you know, issues with the gut that to do with digestive problems and all the rest.
Yes.
So this is your main kind of way of being able to do that. What else could you do in order to help find out and investigate?
Sorry.
They were being distracted by some visitors to the studio, I think.
What was your question? Sorry, madam.
So basically, I was saying we've been talking about colonoscopy and endoscopy and these procedures to get inside and have a look all around that gut. How are we going to move that along then? So you've talked about the blood tests, you've talked about these tests. Then that helps you to identify. Are these always going to help you find out
Not necessarily.
which conditions we're talking
Not necessarily.
about?
So sometimes with what we call the biopsies, they go to the lab, they look under a microscope. In very rare circumstances, most cases, you know, 90% of cases or whatever, we can find out what's going on, and we can try and work out if the stuff is normal or if it's abnormal, or if it's heading towards an abnormal state. And sometimes we pick things up that we didn't even know we were suspecting. Like, for instance, sometimes we can go in and very rarely unfortunately there can be cancers, and there can be tumours and kind of these I guess that's why people get frightened about having these tests, because they're worrying about what you might find. True, but you know, it's like an ostrich sticking its head in the sand, isn't it? If you stick your head in the sand long enough, it doesn't take away the problems. No, and actually finding things early is better for us, isn't it? Because we've got more chance of treatment and care. We've got more options. But sometimes, very rarely, like you said, there are situations when we can't distinguish between different things. Like, for instance, with the ulcerative colitis and the Crohn's disease, as I said, there's a middle ground. Sometimes we can't get those. Unfortunately, it's very rare, but sometimes even TB, the tuberculosis, that can mimic Crohn's disease. Yeah, so certain parts of the bowel, especially like around here, where the end of the small bowel meets the large bowel, those places, you know, it can be really iffy and really kind of indistinguishable. And sometimes we need to do longer, more thorough testing. So there's a lot of jigsaw pieces having to come together. Yeah. Okay. So let's say then that you've done all these investigations, you've found out it's one of these variable conditions. Then what happens for your patient? How are you going to treat them or manage their health? So normally these conditions are looked after by the gastroenterologists, which are specific gut doctors. So like we said, gut problems can be split into medical problems and surgical problems. The general surgeons are the ones that deal with all the cutting and the surgical issues and all the operating. All of the medical issues with the bowel go to the gastroenterologists, and they're a highly specialist team that are just focused on gut medical problems, and they deal, this is their bread and butter, they deal with this every day, and they've got a massive list of ways in which they can try to identify exactly what's going on. They do a lot of these scope tests themselves, the camera tests, they do a lot of that themselves. And, you know, the way that technology is advancing, the amount of stuff that you can do while you're scoping is just becoming phenomenal. And there's lots and lots of things that they can do. Normally what we do is once we've got a diagnosis, we normally start with the traditional ways to do kind of medical management, and conservative and medical management. I'll talk about that in a second, and then moving on to more complicated things. So conservative medical management is kind of basically knowing what your triggers are. So simple things like even stopping smoking can reduce your risk of having. So these conditions like IBD come in. There's lots of people who get them in flares. So you get like a period where you have very, very bad disease. You take some tablets. You get over it. Then everything calms down, and then slowly you could be fine for a few months. You may get another bout of it. And sometimes people get no bouts for many, many years, and sometimes they go through a year where it's just they've got almost continuous disease, active disease, and that can be really difficult because people can think they're doing really well, and then they can trip up. So we manage those. I
guess you become complacent, or you get used to having good health, and then you maybe start to have things or do things that are not good for you. So stress is a big thing, and stress actually is a trigger factor for a sudden flare-up of the IBD. Which we can't always control.
No, you can't control. So stress, cigarette smoking, certain people have dietary effects on their Crohn's disease as well, and having certain dietary input, like eating certain foods, can start to trigger their Crohn's disease or their UC.
We come from the South Asian communities. And how much of an issue are the spicy foods on conditions like this? Is it always the same?
Again, it's really variable. Some people are fine with it. Luckily, in terms of Asian communities, we don't have those are the numbers I gave you earlier about kind of how common these conditions are. Luckily, they're slightly less common in Asian communities than there are in the Caucasian
because that was the question.
Community.
Is there a particular ethnic connection to any of these conditions?
This is quite a lot more, well, we say a lot more common, but relatively speaking, we are less common in the Asian communities, slightly more common in the European Caucasian communities with these conditions. But not to say that we don't get them, we do, and we do get IBS as well.
Sure.
Is
it linked to the way we eat today more than anything, or is it, I know we've said it's stress related and other things as well, but I often wondered the way that, is it because we're better at identifying conditions today because medicine's moving forward, or is it a combination of that and the fact that our diets are changing, the way we produce foods are changing, things are not, the way cattle is fed, all those things I think have a massive impact on the health of and the quality of what we're eating.
So I'm going to give you a really wet answer. You probably predicted anyway, didn't you, Ravina? So my wet answer to that is that it's so multifactorial. There is a heavy genetic element to this. So lots of people have, this runs in families. If your mum or your dad or first degree relative had IBD and you come into me and you've said, I've got bloody diarrhea or something, then my alarm bells would be ringing that there is something that may be it doesn't necessarily mean that, but it could mean that. We need to investigate that more and treat it a lot more seriously. Not that we wouldn't treat it seriously if you didn't come in with that, but it just makes us think a bit harder. Also, I think you're probably right in that we are now picking up these things a lot more than we did before, and we are probably managing them better, and people are living longer, and it's a combination of things. That can be said for a lot of different conditions. These conditions tend to be what we call, they tend to be long-term inflammatory conditions, but there's not really a clear external trigger. It seems it's an autoimmune disease, which means that it's your own body on some level interacting with itself, which makes it a bit harder to sometimes rationalise in your head as to, what could I have done that made it better.
It must be so frustrating for people that have to live with these conditions, because there's just no one thing that you can put your finger on all the time.
At the moment, there's no cure. There's no cure for them. The reality is that from literature, 50% of people with Crohn's disease will require surgery within 20 years of the diagnosis. So half the people that are diagnosed with it will need surgery within the 20 years. With ulcerative colitis, it's something like 30% of people will need a colectomy, which is basically a removal of their large bowel, a surgery to remove the whole of their large bowel or part of their large bowel within the lifespan of after having been diagnosed with the condition. So 30% is a big number.
Yeah.
So my point is that medical management is important, and sometimes we need to just try with medical agents. So we give a lot of steroids, we give painkillers, we give sometimes what we call antispasmodics, which are basically things to relax the muscles inside the bowel and help stuff to move along a bit easier.
And when you say medication and methods like that, my automatic response goes to, gosh, there must be so many side effects with these things as well.
Yeah,
so
unfortunately.
you're combating that on top.
Yeah. So and steroids have the list of
don't have a good press.
side effects. No, the list of side effects from steroids. We're not talking about steroids at the gym. That's really really clear, because some people have a hint in their head that steroid means like, you know, what you get pumped with. It's not that. These are specific medical steroids that are used in a very, very scientific way. They've got measured responses. We use them in a really particular way and in the safest way possible. We stop using them when we don't need them. Having long-term steroids can be detrimental, and it can affect you. The list of actual side effects from steroids long-term, you know, there are separate conditions you get just from using steroids long-term. So we don't like them, but unfortunately they become necessary sometimes to try and control flares when these things happen. Also, you know, some of the other medication, the newer medication that's coming through to try and control these diseases, it actually helps. These medications, they're really new. Some of them are, you know, not hit the market yet. Some of them have been around for like 10, 15 years, 20 years. They are used to dampen your immune system, which basically means you're kind of tricking your body into not reacting to whatever the process is going on. They're very good at what they do, and they sometimes stop these conditions. You can take them long term. You can take them in different combinations. So you can use 2 or 3 of these drugs sometimes in different variations. And massive clinical trials have gone on. This is research based. That's the most important thing.
Yeah, and I think it's taking us away from actually what we want to be focusing on. But I think that in itself is a subject we do need to cover at some point, because I think there's lots of our audience out there like me who'd be sitting here thinking, I worry about medication. I wonder whether it's worth. You know, you're constantly weighing up whether it's better to take them, knowing that they have side effects and other complications. And you know, so I think that's another show maybe we need to look at.
So, but unfortunately, sometimes with those medications that numb your immune system and stop these conditions from taking hold of you.
You've got to weigh it up, haven't you?
The opposite end of the spectrum, unfortunately, the side effect of that is sometimes it can lower your immune system so much that you can actually increase your risk of developing certain conditions, such as, unfortunately, it can increase your risk of cancer. It can increase your risk of developing horrible infections as well, because your body's not as policing itself as it would normally, and cancer, unfortunately, can happen.
Raj, we've come right to the end of the programme. We've literally got less than a minute left.
Sure.
So I guess what would be useful would be to say, what are your top tips for the subject today? How would you want our community out there to think about how to look after themselves? Yeah.
So again, really simply, bowel problems are really, really common. You need to know what's normal for you. Anything abnormal, go see your doctor. Try and keep a healthy, varied diet. Eat small quantities and often. And if there's any problems and you're struggling in any way, shape or form, seek some support, seek some guidance, and go see your GP to make sure that you can stay on top of it. The earlier it's diagnosed, the better it's managed.
That's really helpful. Thank you very much. I look forward to seeing you again for our next contribution.
Thank you.
Okay, everybody, it looks like we've come to the end of a show that always seems to go so fast for me. I hope you found it useful. So many more things that we can talk to you about. If you've got any topics out there that you think you'd like to hear about, feel free to ring the station and let us know, and we're happy to look into that. In the meantime, I hope you are looking after yourselves and that you remember me in your du'as. Assalamu alaikum wa rahmatullahi wa barakatuhu.